Hello, everybody. My name is Vesna. I've been a registered nurse since 2022. This is my second year in Athabasca University's Master of Nursing program, and today I will be talking to you guys about my position on harm reduction, that it should be a requisite health service. Before we begin, I would like to outline the structure of this presentation. I will first give us the context of substance use in Canada, more specifically opioid use, and provide some key definitions regarding my stance. Then, I'll provide my arguments as to how harm reduction is essential, effective, innovative, and a human right. Finally, I will share a summary of my stance and arguments. So, for context, substance use rates in Canada are tracked every 2 years by the Government of Canada using the Canadian Substance Use Survey. Over 36,000 participants were recruited, with 2,400 participants in each province participating. I want you to take a look at the numbers. It looks that alcohol consumption was the most prevalently used substance, followed by cannabis, sedatives and opioids, cigarettes, and lastly, stimulants. I want you to look at the numbers saying 1 in 10 Canadians used opioids and think about how, although substances all have associated harms, not all harms are as prevalent in our system. What do I mean by this? Well, many of us have heard of the opioid crisis, but how does opioid use in 1 in 10 people translate into a crisis? Well, the Government of Canada has projected that opioid toxicity and associated harms is responsible for 95 emergency medical responses per day, 64 emergency room visits per day, 15 hospitalizations per day, 18 deaths per day. So, populations disproportionately affected by opioid related harms include those living in poverty, those of chronic pain diagnoses, those of Indigenous identity, trades workers, as well as males. Before I begin to talk about my stance, I want to share some key terms that are within my stance. First off, harm reduction. So, harm reduction began in the 1980s by people for people. Various definitions and methodologies emerged, but we can describe harm reduction as a public health approach aiming to mitigate the harms associated with risk behavior. Programs that fit under the umbrella of harm reduction for substance use include safe consumption sites, safe equipment, access to rescue drugs, safe supply, access to treatment, amongst many more. When we think of health services, we can define them as any action taken by health professionals to assist people in reaching their best health outcomes by either prevention, therapeutic intervention, promotion, or rehabilitation efforts. Lastly, the word requisite, as we know, is another term that describes something that is mandatory, necessary, or needed. Hence, I propose that mitigating the harms associated with substance use is a mandatory commitment by health authorities to prevent further negative health outcomes associated with substance use. I argue that harm reduction is a requisite health service given its essentiality, effectiveness, innovation, and that it is a human right. We come to my first claim. Harm reduction is an essential healthcare service. Per the Government of Canada, essential services include any service necessary for the safety or security of the public or a segment of the public at any time. The Government of BC also purports that for a service to be considered essential, it must preserve life, health, and ensure the safety of a functioning society. So, how do we know that the interruption of harm reduction programming interfered with life? Well, take the COVID-19 pandemic, for example. There was a 60% rise in drug toxicity deaths in Ontario during 2020 due to the disruptions and closures of harm reduction clinics and programs. This accounted for 2,400 deaths. These are 2,400 deaths that could have been avoided if harm reduction services maintained a priority public health service. Daly and I'll also say that the lack of funding for safe consumption sites leads to more use in public areas, which impairs the safety of people who use drugs by not having access to rescue services. I also want to point out that as harm reduction clinics began reopening, coroner reports have shown a decrease in drug toxicity deaths, showing 19% of opioid deaths decreasing in the past 12 months. So, denying the essentiality of harm reduction is outright discrimination for people who use drugs, as these services have shown evidence of being essential to preserving their lives. Therefore, access to harm reduction services can save lives, crediting these services as being essential. The next point that I have to share is that harm reduction is effective. For a service to be deemed effective, it has to be able to achieve its desired results. In comparison to abstinence programs, stigma, discrimination, and the criminalization of drugs, these efforts have all failed in reducing substance use and its negative consequences for one key reason. They failed to meet people where they are at. People who use drugs are impacted by legislation, systems, employment, their housing situation, and many other environmental barriers that impact their roads to recovery. Instead of providing barriers to accessing health services, harm reduction provides services to mitigate as many harms as possible related to substance use, including reducing the transmission of bloodborne diseases from needle sharing, as well as reducing overdoses and poisoning due to unsafe supply. Bridgen et al. And Lewis reference hundreds of articles indicating the successes of harm reduction in lowering the rates of overdose, Hep C, and HIV. Therefore, there is ample evidence that supports harm reduction services as being effective in meeting their goals. My next point is that harm reduction has a promising evolution in that it is innovative. Critics of harm reduction claim that harm reduction efforts are flawed, providing an anxious attempt of a safety net rather than addressing the wider structural problem of substance use. However, critics fail to give credit to the innovative approaches initiated by communities, like Toronto's mobile harm reduction clinics, as well as frameworks, such as the Harm Reduction Collaborative Framework for Policy Systems Environmental Change. These programs have all been working to respond to the immediate needs of people who use substances, as well as influencing their oppressive environments by fostering authentic partnerships to effectively respond to the substance use crisis. More specifically, the Harm Reduction Collaboration Framework by Miller et al. Provides a guideline on planning which sectors, for example, policy, systems, environment, require adaptations to meet the needs of those of substance use. Examples of solutions generated by this framework include the decriminalization of syringes and injection paraphernalia through changes in legislation, the forming of therapeutic relationships between health providers and pharmacies to support people who use substances, the enrollment of specialists to on site harm reduction facilities, as well as developing relationships with infectious disease providers. These are among the many responsive solutions generated by the framework. Hence, the innovation brought about by harm reduction efforts holds potential to a promising future in addressing the harms associated with substance use, marking them as innovative. Finally, harm reduction is a human right. The United Nations describes human rights as inherent to all human beings, regardless of race, sex, nationality, ethnicity, language, religion, and any other status. Human rights include the right to life and liberty, freedom of opinion and expression, and many more. Everyone is entitled to these rights without discrimination. Discrimination is set out as the following: an action, behavior, decision, or omission that treats a person or a group of people unfairly and badly for reasons linked to personal traits. Even rules, practices, procedures that seem harmless can cause discrimination if they have the effect of putting certain groups of people at a disadvantage. This is a definition provided by the Canadian Commission of Human Rights. So, I want to point out that ill-informed members of the public often view those who engage in substance use as incompetent or pathological. These perceptions have produced mass stigma towards substance use, impacting people across sectors, resulting in discriminatory interactions towards people who use substances, which has led a decrease in help-seeking behaviors within this population. I want to remind everyone that substance use does not discredit one's human rights, nor does it permit discrimination. People who use substances have the right to participate in decisions that affect their health and life. Harm reduction supports access to health services for people who use substances. Therefore, harm reduction is their human right. In summary, harm reduction can be credited as a mandatory health service, given its ability to preserve the rights of those who use substances, reduce morbidities associated with substance use, derive innovative solutions to immediate risk and structural risk factors related to substance use, and in upholding the human right to health. So, before I leave, I want to close off on a quote from Betty Lou Christie. She's a chair member of the Minister's Patient and Family Advisory Council. So she says that she lost her son, Pete, who was a 25-year-old with concurrent disorders, to an accidental opioid overdose 20 years ago. She saw people being trapped in cycles and the continued condemnation of people who are genuinely unwell but not having their needs met. Life saving and life sustaining services must be a priority. People need opportunities to survive long enough to find their way to recovery. Every person deserves healthcare options along the full continuum of care. So, thank you everybody for listening to my presentation. I hope this gave you guys some food for thought about harm reduction and how it should be a requisite health service. Thank you so much, and I hope you guys all have a wonderful day. Take care.